Okay, so we'll start with gastrointestinal hemorrhage. This is a pretty dense slide set. I'll blow through some of the, particularly the comments about the interactions from a pharmacologic standpoint. I would think those would be ripe question for boards, but they don't appear to often be on them, but they're there for your use. GI bleeding in the ICU, a very common cause of admission to the ICU, a significant cause of morbidity and mortality. And we'll talk both about upper and lower GI bleeding, where the difference is divided by anatomically the presence of the ligament of Treitz. So everything above the ligament of Treitz is considered an upper GI bleed, and lower for those below. The vast majority of upper GI hemorrhage in the ICU patients is due to ulcers. Certainly stress-related mucosal injury can occur as well. That has decreased markedly well before the introduction of both the H2 receptor antagonists and the PPIs. And I'll have a few comments as well on portal hypertension and variceal hemorrhage. I know you received excellent lectures on that on day one. And a few comments on the common causes of GI hemorrhage, lower GI hemorrhage, diverticulosis, AVMs, ischemic colitis, neoplasm, and whatever form of enteric colitis. So just very quickly, the most common cause of a lower GI hemorrhage or hemorrhage from your lower GI tract is A, colonic ischemia, B, diverticulitis, C, diverticulosis, or D, an upper GI bleed. Okay, and this is to remind most of you that you know, and perhaps you can argue it's a question of semantics here, that when you see blood coming out of the lower GI tract, of course you should remember that most often it's coming from a very rapid upper GI bleed. So GI bleeding at some level is extraordinarily common in our patients. If you stuck a scope in every ICU patient, almost all of them would have some evidence of petechial hemorrhage. Overt bleeding, less common. This is where you see coffee ground emesis or aspirates. They, in fact, do increase the length of ICU stay and mortality. However, clinically significant bleeding, very rare, less than 5% of patients. These are patients who become hemodynamically unstable, who drop their hemoglobins and require transfusion to treat. This is certainly associated with an increased mortality, as noted by Deb Cook many years ago. Patients who bleed earlier in their stay, however, are not as prone to dying as those who bleed later in their stay, often in the constellation of multi-organ failure, and there certainly is an attributable length of stay to having a significant GI bleed. So I said ulcer, the most common cause of upper GI bleeding in the ICU, associated with a risk of H. pylori, but we'll talk a little bit more about that a few slides hence. NSAID certainly, and less so with acid. So this is not an acid problem in ICU patients. So these patients present most commonly, although not all of the time, with hematemesis, then melena, hematochezia, despite my first question, even rarer, mortality rare as well. So second question, the most appropriate treatment for a rebleeding ulcer initially treated via endoscopic cauterization 2 days earlier is A, angioembolization, B, go to the operating room and do a laparoscopic vagotomy, C, total gastrectomy, or D, repeat endoscopy. And true, it's certainly worth doing this, looking again and seeing, whether it's possible to do something endoscopically. Certainly I didn't give you enough information that if this patient were hemodynamically unstable and had, been 6, 12, 20 units into that, you may be more inclined to do something more aggressive, but I think that's a fair answer given the information you got. So don't forget, of course, in a patient who's significantly bleeding from an ulcer to consider protecting the airway, appropriately resuscitating with blood products. and then certainly by the nasogastric lavage, estimating how much bleeding is going on, as well as with your serial hemoglobin determinations. So both for endoscopic therapy and risk stratification, endoscopy playing a very large role, and there's a clip on a bleeding ulcer. So ulcer treatment, generally to eradicate H. pylori. We'll talk more about that in a bit. We'll talk about H2 receptor antagonists versus PPIs. Endoscopic therapy can include cautery, can include clipping, sclerotherapy or an epinephrine injection, angioembolization, and it's rare that patients require my operative services for their GI hemorrhage, whether by ligation of the ulcer, excision, vagotomy, or enterectomy. Extraordinarily rare. Hydrochloric acid or acid hypersecretion is really not the most common cause in ICU patients with GI bleed. However, here is the acid story. It's stimulated by gastrin, histamine, and acetylcholine, the latter by vagal stimulation. The final common pathway in this acid story is, of course, through the cyclic AMP calcium pathway that ultimately activate that hydrogen potassium ATPase pump, and that's therefore the rationale for using proton pump inhibitors and H2 receptor antagonists. So what is the H. pylori story? It's interesting if you actually look only at ICU patients, the evidence is not as compelling as it is in outpatients, in that patients with H. pylori don't necessarily bleed, and patients who bleed don't necessarily have H. pylori, but it's still probably safe to be cognizant of that and answer such on your boards. So in the antrum, it causes hyperacidity, which promotes duodenal ulcers. However, interestingly, if you drop H. pylori in the body of the stomach, you're actually going to cause achlorhydria and a gastric ulcer. As you know, there are strategies for using either triple or quadruple therapy, and I've put the agents there. And you certainly should prove that you've eradicated the agent before discontinuing your therapy. So, what do the trials say about this? This is the latest Cochrane review about it. Once again, not specific to the ICU, so these questions, really very little great data about H. pylori in the ICU. But anyway, it says that if you do either the triple or the quadruple therapy for H. pylori in terms of ulcer healing, you're going to do better for duodenal but not gastric ulcers. However, for ulcer recurrence, the quadruple therapy versus just using standard ulcer medications is going to be more efficacious for gastric rather than duodenal ulcers. Stress-related gastric mucosal injury, not nearly as common as it used to be. We're certainly better resuscitators than we were in the past. And this really begs, as we talk about some of the side effects of the agents, that we way overdo, I believe, stress ulcer prophylaxis in the hospital, and there certainly even in the ICU, I think we're overdoing it, and that'll come back when we talk about the agents again. So prophylaxis decreases the risk of rebleeding by 50%, and once again, the bleeding of a magnitude from stress bleeding, getting to the point of needing surgery is really incredibly rare, such that there are just no contemporary series on surgery for this disease. It's proximal, it's early bleeding, this stress mucosal gastric bleeding. These are petechiae that eventually have a full thickness erosion. Later bleeding is more distal, and as we've said before, has a higher mortality associated with it. And it's usually a different mechanism and in the constellation of multi-organ failure. Okay, so this is a have you been paying attention kind of question. The etiology for GI bleeding due to peptic ulcers versus stress bleeding respectively is, are peptic ulcers acid or H. pylori, and is stress bleeding H. pylori, acid, or ischemia? Okay, and as we've said, H. pylori, peptic ulcers, although I've certainly confused you potentially, that not as big in the ICU as we might think, and stress bleeding from ischemia. Okay, so let's talk a little bit more about these and then the agents. With impaired gastric mucosal protection, it occurs with bile salt reflux or uremia that results in breakdown. Also, potentially, there's decreased synthesis of the barrier as well. So we break it down and we don't move it. Now let's talk a little bit about the epidemiology of bleeding in these patients. Strongest risk factor in the ICU, A, coagulopathy, B, MEC-vent, C, TBI, or D, renal failure. Okay, good. And we'll see that in the upcoming slides, that this is not new data, right? 1994 Deb Cook's data that the greatest risk is mechanical ventilation. So, this should prompt your therapy. A ventilator equals some sort of ulcer prophylaxis, which we'll talk about. Coagulopathy, another significant risk. Really the overall risk not phenomenally high, but, those are the two that increase it as well. Yes, renal failure can cause it as well. There are other diseases that can result, but those are the two biggies. This is the VA study from about the same time period that also reminded us that liver failure patients are certainly at high risk as well. And for the surgeons in the room, from the latest EAST guidelines on this, recognizing the Deb Cook studies, coagulopathy, mechanical ventilation greater than 48 hours, a history, and then they talk about the minor risk factors. And generally, those patients are ventilated, so those should be your indications for using the agents. So I would say certainly that antacids and sulcrophate are largely of historical interest. I mean, one would almost argue that H2 receptor antagonists are of historical interest, but maybe they will sort of come back into the fore with some of the latest concerns about PPIs. So the H2 receptor antagonists, once again, work through that cyclic AMP pathway. They include agents that vary in potency, vary in the route of administration. You certainly can develop a tolerance to the effects. Once again, I would think that these would be prime for board review questions, but certainly on the surgery boards, we've not seen this. And here I talk about what the interactions in terms of the cytochrome P450 system are and the various different moieties. We obsess greatly about the risk of thrombocytopenia with this agent, and it's certainly heightened in those with renal hepatic dysfunction or in the elderly, but probably less common than we give it credit for. If you're going to use an H2 receptor antagonist, famotidine appears to have fewer, particularly P450 interactions. PPIs, once again, work through that pump. They are more effective, at least in raising the pH. Whether they're more effective in providing ulcer therapy, we'll get to in several slides. Once again, various agents and various routes of administration. They are absorbed in an acid environment, or they impair drugs that depend on an acid environment, and they increase the absorption of those that are in an alkaline environment. And here, once again, for your reading pleasure, are the various interactions that you see with the PPIs. These are provided as prodrugs that are activated once they bind to the cell, so their duration of action is actually longer than their stated half-life. They activate faster if they have a higher pKa, so you'll see the various agents and their efficacy there, and once again they also activate faster in an acid environment. Because of their acid lability, they are enterically coated if they're delayed release, which of course impairs their absorption, and it's reduced in the presence of food and other acid-reducing agents. This is probably not going to show up in your boards, but I think at least as critical care practitioners, it would at least make me to think about, why is it that we've come to PPIs? Why are we using them so extensively? This is the 215+1 study that used big data to establish this relationship, and established a pretty significant relationship between the use of PPIs, once again not specific to the ICU, and MIs, and interestingly, higher in young patients without any apparent cardiac risk factors, and even higher in those with obvious risk factors. And this is thought to be through a nitric oxide pathway. So likely won't show up on your boards, but may years from now, and certainly should prompt us to think about whether these agents should be used as extensively and whether we should be thinking of others. There are several meta-analyses that derive different conclusions as to which you should be using. This one was published in 2010. This has 7 randomized controlled trials in it, and they show that absolute risk reduction for GI bleeding, 4% if you used PPI risk. After you took one outlying trial out, it was down to 2%, and their bottom line was it really didn't matter whether you used H2 blockers or PPIs. So if you would worry about the side effects of those, at least this Lynn study meta-analysis would prompt you not to use it. However, 2 subsequent trials published and reviewed patients that were missed by that prior meta-analyses, and in this one they came strongly in favor of the use of PPIs, both in terms of significant and over GI bleeds, and neither agent caused a change in pneumonia mortality length of stay, and there was no comment on C. diff, which we'll talk about shortly as well. This is interesting. It's an old study that looked on, you were randomized to sucralfate, an H2 blocker, a PPI, or nothing. And interestingly, there was absolutely no difference in the groups, suggesting that whatever is happening in the ICU probably predated our use of these agents. And once again, a very small study, but shows that there may be a role for nothing. Probably more relevant to our patients is this study from Merrick, which was a meta-analysis, which suggested, and once again here, the agent in question were H2 blockers versus nothing, and the nothing here actually was using enteral feeds, and suggested that if your patients are being enterally fed, perhaps they do not need any prophylaxis. Once again, the risk of pneumonia, the thought is that if you raise your gastric pH and you aspirate, you can, in theory, have a higher incidence of pneumonia. And certainly Deb Cook's work earlier suggested that, that the H2 blockers, and remember this was predated the PPIs in use, was at least minimally increased versus, at the time, sucralfate, but not statistically. There is, however, a relationship between PPIs and C. difficile. They have been demonstrated to increase the risk of infection. You may be asked this. However, I would note that these studies have not been done in ICU patients. And then a few comments at the end on portal hypertension. I know you received an excellent 2 lectures on liver disease and its sequelae. Once again, by far the most common cause of liver failure, and its side effects are going to be alcoholic cirrhosis. There are certainly other reasons which can lead to liver failure, which can then lead to variceal hemorrhage. The mortality from an acute bleed from this is certainly much higher than from all the other bleeding causes we've discussed, and certainly with every subsequent bleed, your risk goes even worse. In addition, or as a result, or the etiology of that is every subsequent bleed significantly impairs your liver function, encephalopathy worse, coagulopathy worse, and just general liver function gets worse, and so you end up in a spiral unless you treat it. Next question, in addition to octreotide, which pharmacologic agent should be administered for an acute variceal bleed? Propranolol, intravenous nitroglycerin, vasopressin, or 3rd generation? Good, and the correct answer is the antibiotic. Once again, we'll talk about that in a few slides, but remembering the relationship that this causes potentially through translocation an increase in the risk of bacterial peritonitis. So what do you do in an ICU patient with this type of bleed? So once again, unlike all the other the upper bleeds that we were talking about before, this is the real deal. For sure control the airway, for sure get great access, resuscitate. The coagulopathy is going to be a problem. The encephalopathy needs to be managed. Acid reduction, certainly. Octreotide has taken over for older therapies. Remember that beta blockade is a prophylactic agent, so the propranolol these patients are on is given prophylactically. It's not used therapeutically. The cornerstone certainly now is endoscopic therapy, and certainly further modalities for treatment, tips, and then certainly as the MELD increases, transplant consideration if they're otherwise appropriate. These were awful years ago when we used to have to do these, the surgical solution. They're never satisfactory. The one sort of potential thought about surgery in these patients is the isolated patient with a splenic vein thrombosis. Actually, a splenectomy may be, God forbid, if you have to operate on them, beneficial in these patients. So what do you do in terms of active bleeding general patients? PPIs in the face of active bleeding ulcers. They do decrease the risk of rebleeding and the need for surgery, but not mortality. Still thought to be beneficial to use. Should you use PPIs before you do the scope? Yes, once again, a nice Cochrane review on this. You're not going to change the mortality, once again, probably because it's not that high to begin with, but actively decreases active bleeding and the need for therapy at the time of it, so you should do it. So the gastroenterologist came up with a set of guidelines that said what should you do with an active upper GI bleed, particularly those who are sick and in the ICU. Resuscitate them, use PPIs before your EGD. So these are for actively bleeding patients. Please help us out, use some prokinetics so we can see a little bit better. We need to come in and do this urgently for those indications. And once we see and do what we've done, please keep them on the PPIs for 72 hours. So here's the reminders for the cirrhotics with particularly ascites, but in general for every one of them, the prophylactic antibiotics here appropriate. There are actually no great recommendations for the use of blood products, adjuncts in these patients. A couple comments on lower GI hemorrhage. Less common reason for ICU admission. More likely it will stop spontaneously. However, if it doesn't, these patients are more likely to come to surgical management. And once again, we said source distal to ligament detritus. Colonic sources more common and easier to manage. Small bowel sources difficult to diagnose and to localize in these patients. So colonoscopy is the diagnostic modality of choice now. It wasn't, way back years ago when I was a resident. It's very accurate even in the face of bleeding. If you can get around and get away with preparing the colon, that would be very nice. You may be able to provide therapy through the scope as well, but remember that as opposed to the stomach and the upper tracts, blood supply less reliable, less redundant. So if you take out a vessel therapeutically there, you may cause ischemia, which will worsen the situation. You need a certain bleeding rate if you're going to go to angioembolization. It certainly can be more selective and helpful in these patients. And once again, this is an example of a colon that is ischemic, and therapy here is very difficult. High mortality rate, once again, is generally in concert with multiple organ failure, multiple causes, certainly from the venous or the arterial side. Non-specific presentation until the colon is actually dead, and certainly a scope is going to provide your answer. So stress bleeding, very common at some level, but really generally subclinical. Early proximal, really rarely of clinical significance. Distal, usually related to ulcers. ICU stress bleeding is an ischemia, impaired mucosal barrier issue, less so due to acid secretion and H. pylori. Once again, the most potent risk factors for upper GI bleeding in the ICU are mechanical ventilation greater than 48 hours. Second is coagulopathy. Therefore, prophylaxis should target those with those risk factors and a recent risk of GI bleeding as well. H2 blockers are efficacious. You do, however, develop a tolerance to them. PPIs probably more efficacious than H2 in terms of bleeding, but not mortality. Probably no difference in length of stay or pneumonia. However, they may increase the risk for C. diff infection, although not specifically in ICU patient population. And then once again, that latest study that questions and lays out the cardiac risk of these. There may be a role for doing absolutely nothing in some of our patients in the ICU, even in the high-risk patients, provided we're feeding them. If the patients are actually bleeding, we should give them PPIs prior to endoscopy and continue for 72 hours after intervention. Variceal bleeding, torrential bleeding, best medically or endoscopically management. Remember prophylactic antibiotics, and lower GI bleeding, less common in the ICU. Thank you.